A couple of you join in now, so we'll go ahead and start talking about Malteses. So this is our second Instagram Live where we are doing a breed breakdown. A couple months ago we did Frenchies, so this month we're going to talk about the Maltese breed. So these are really gregarious little creatures. They are super affectionate and love to be near their owners and near new people. Average life expectancy for this breed is somewhere between about 12 and 15 years. Some, obviously on either ends of that range. They're a pretty popular breed, so they're about the 37th most popular breed as far as registered pure breeds with the AKC, so we'll see a lot of them around. There's a lot of rumors about where this breed originated, so kind of what we know about them is they started around South Central Europe. There's rumors that they started in the island of Malta, and also rumors for some cities in Italy. I think there's some back and forth on that, but developed in Europe and then obviously spread across the world. They're known to kind of be like a royalty breed. They're very prim and proper, but for toy breeds, they can also be pretty feisty and actually do make good watchdogs and love to bark at anything that's abnormal going on. So we'll talk a little bit about this breed, and we're going to talk a little bit about some of the most common neurological conditions that we're going to see in this breed. So the big ones that we're going to cover today is we're going to discuss necrotizing meningitis. So this is a specific form of autoimmune meningitis or immune-mediated inflammation of the nervous system. We're also going to talk a little bit about hydrocephalus, so an increase in fluid built up in the nervous system. Other diseases that we'll talk about is COMS, or Caudal occipital malformation syndrome. We'll touch a little bit on deafness, so not being able to hear. And then lastly, we're going to talk a little bit about a stranger inflammatory disease of the brain that we call idiopathic tremor syndrome. Other names for that include little white shaker syndrome or also cereballitis, idiopathic cereballitis. And we'll have some nice MRI pictures of all of these diseases. We'll talk a little bit about how they're diagnosed and treated. And we also have some videos at the end for one of the diseases. So we'll go over those as we move along. All right, guys, so we're going to go ahead and switch gears here and talk a little bit about our first disease. And so this disease is going to be called necrotizing meningitis. So Maltese breeds, unfortunately, are predisposed to developing inflammation within their nervous system. So what we call meningitis encephalitis. In general, we'll call this disease meningoencephalitis of unknown origin or unknown etiology. So we know that this disease tends to be immune-mediated, so there's not a bacteria, there's not a virus that we know of that predisposes or causes this meningitis, but truly it's the immune system kind of attacking the nervous tissue inappropriately. There's a couple of different forms of this meningitis, necrotizing meningitis being one of them, and obviously, like we said, more prone in the Maltese breeds. So this form of MUE or MUO can be pretty devastating and unfortunately tends to be a more aggressive type and can be life-limiting and can be difficult to control. So we have a nice little MRI picture here for you. So generally what we'll see with these patients is it kind of just depends on what part of the nervous system is being affected. So sometimes they'll present for behavior changes, sometimes circling behavior, sometimes balance dysfunction. Anywhere that there's inflammation bad enough to cause dysfunction of the brain, those are the signs that we may see. Generally, physical exam will be normal for these patients. They can have very normal blood work, very normal x-rays. But what we can find once we've done a neuro exam and kind of localized the problem and scan, generally it's going to be the brain with the necrotizing, is we'll find these areas of inflammation. So looking at the picture here, there's a little green arrow that is pointing to the bright white little stretch there in the brain. So that is inflammation, and it's actually formed a cavity, so there's necrosis, and that's where that necrotizing name comes from. It can be, like we said, very difficult to control because of the extent of damage that it causes. So once we've assessed this patient, done an MRI, we do like to generally perform a spinal fluid tap or a spinal fluid analysis. So this is where we actually sample the spinal fluid of the patient and we look for the concentration of protein that's there in this fluid, and we look for the number of cells that are present. As you can imagine, you want your spinal fluid to be a very quiet place, so it should look like water, it should have very low protein counts, very low cell counts. But in these necrotizing meningitis, sometimes we will see very elevated proteins, very elevated cell counts, and we can see cells that are involved in immune-mediated attacks, so lymphocytes, sometimes neutrophils, and it can help us kind of lean toward this disease process along with our MRI. So when we have kind of diagnosed these patients, the next step is, how do we treat them? I had a lot of questions come in about this disease and regarding Malteses, and I'll go through them, specifically some questions that were sent in earlier, so we'll do those at the end. But to kind of cover some of them, the main staple point of treatment for these patients is immunosuppression. So you want to lower the body's immune system response to protect the nervous tissue and to keep it from attacking that nervous tissue. For the most part, we generally will achieve this in the short term with steroid medications, so drugs like prednisone. They are the fastest acting, so we'll bring them in early, and then we'll try to wean them away as time goes on, and we'll go over some specifics in the questions that we have. There are other drugs that we can also add in, so drugs like Cytosar, mycophenolate, cyclosporin, among some others, have been shown to try to help treat this disease. So we use those drugs, and Cytosar is one that I'm more familiar with. It's actually a chemotherapy drug that we use at very low doses to try to bring down the number of inflammatory cells being produced from the bone marrow. Mycophenolate and cyclosporin are drugs that are used to suppress the immune system and have been used in organ and like kidney transplants. So also just suppressing the immune system from doing its job, keeping it from rejecting an organ, but in this case, keeping it from attacking the nervous tissue. As we move forward with those patients, we are generally trying to slowly wean down these medications or slowly wean them off these medications over a period of time. Some patients cannot completely come off of meds and they need some dose long term. If we do have a clinical suspicion of necrotizing meningitis based on the MRI and the breeds that are present, we sometimes are way more cautious and don't fully try to bring them off of some of these medications. Again, very case dependent and very dependent upon the doctor there. We'll go over some more specifics. Like I said, we have some of those questions that were submitted in advance. So we will talk a little bit about some recent research for these pets. If you give me just a moment here. Not sure if I see that picture.
Oh, which one?
It was just the... no, that's okay. So I had a picture of research. If you guys are interested, I can post that. But we did have a nice little article that came out in the last couple of years where they actually did a genome-wide association study on Malteses, pugs, and I believe Chihuahuas specifically. And they actually found, for both pugs and Malteses, that there are some genes that are actually in their genome that predispose these patients to potentially have this over-responsive immune attack on the nervous tissue. For Malteses, I think specifically it was chromosome 5 and 14, but all of these genes help code for the immune system. And so it's helpful to know that as a breed that they can be predisposed and that we can find evidence that this is an immune-mediated disease that we're seeing in these patients. All right. So now we're going to switch gears. We'll talk about another common disease that we see in this breed. So this is hydrocephalus. So this is an excessive amount of spinal fluid that accumulates in the brain. So to kind of give you some orientation on this MRI image here, the single arrow on one side is pointing into the big white bright area. That is all spinal fluid that has accumulated within this dog's brain. If you see the two arrows that are coming in on the other side, they're pointing to the little gray line. That's the little bit of brain tissue that has been left in this patient. So this spinal fluid has expanded and expanded, and the brain tissue has shrunk and shrunk until we don't have a whole lot of normal brain tissue left. So this is a very common finding in young patients. So we do also see this happen as a congenital problem, so a from birth malformation. There's special tubing for the spinal fluid to flow out of the brain and into the spinal cord and to be reabsorbed. And sometimes that tubing will be stenotic or closed, and this fluid has nowhere to go. It's constantly being produced by special tissue in the brain, and it starts to expand and expand and expand, and it has nowhere to go. So clinical signs that we may see in some of these patients, again, depends on which part of the brain starts to be affected first, but you can see lots of balance dysfunction, falling, spinning, circling. You could also see behavioral changes, being very dull, not playful puppies, and then sometimes seizures and some other more severe signs. For these patients, we can diagnose them in a couple of different ways depending on what's going on with them clinically. So they'll often have normal blood work. They may have a very dome-shaped head if we do x-rays, and sometimes they talk about a ground glass appearance because of how much fluid when you're looking through the skull on the x-rays. But by far the most sensitive things to do would be more advanced imaging, so CT or MRI, with MRI being the best for the brain, and you can actually detect all the pockets of this fluid. Sometimes we will add in a spinal fluid tap for these patients. Sometimes they can have concurrent inflammation on top of hydrocephalus, but if it's pretty obvious sometimes, or if it's unsafe, sometimes we won't do the spinal fluid tap for these patients. For treatment for these patients, there's two paths. So there's a medical management treatment, and there's also some surgical options. So for medical management, the goals will be to decrease the spinal fluid production as best we can. There isn't a full off switch for spinal fluid production, but there are some medications that have been shown to help decrease it. Specifically things like prednisone, and there is some research for omeprazole. So prednisone is a steroid, and omeprazole is actually an antacid, the generic form of Prilosec. And so there's some evidence that reduces the amount of spinal fluid being produced. Prednisone will also help with the pressure and inflammation. It cannot fully take away all the fluid that's present, but some patients do stabilize and hold steady. If a patient doesn't respond to medical management, or if they decline, or if their signs are severe, we do have the option of considering surgery. So surgery for hydrocephalus patients generally includes what we call ventriculoperitoneal shunting. And so it's just a fancy term for taking fluid from the ventricles of the brain and actually putting it down into the peritoneum of the abdomen, and basically providing an overflow, so to speak, of where that spinal fluid can go. Is a little bit of an involved surgery, so we do talk a lot about recovery periods. These patients do have a lot of monitoring and follow-up that they have to go through. Shunting, just like in people, is not a perfect end-all be-all solution, so we do have to watch them closely. Sometimes the complications we'll see is infection or the shunt failing. Either it gets clogged, it moves out of the way, they feel great, they start running around, tubing gets knocked out of position. So those would be things that we worry about, talk about. We follow these patients out pretty closely. Similar to people, dogs that have these shunts placed, a chunk of them by about 2 years will have some form of a complication and may need to have the shunt revisited or replaced depending on that patient. But these are definitely patients that we keep close and check frequently and make sure that we don't see signs of worsening. All right, so we'll move on to our next disease process here. So the next one that we're going to talk about is COMS, which is an acronym for Caudal Occipital Malformation Syndrome. So another name for this would be Chiari or Chiari-like malformation. So Chiari is the name of a similar disease process that we see in people, where they have a malformation at the back of the skull, and the back part of some of the brain tissue will actually come out of the hole in the back of the skull where the spinal cord should be. The anatomy is a little bit different, so some veterinary neurologists prefer not to call it Chiari or Chiari-like malformation and kind of reserve that for people. And so a common term that we use in animals is Caudal Occipital Malformation Syndrome. So what this all entails is, like we said, a malformation of the skull itself. We have bred a lot of dogs to kind of be compact, and in that process we have shortened up their faces pretty significantly because it makes them look very cute, but unfortunately can also cause some issues. So I have an MRI image here of a dog's brain. So the brain is kind of pointing off in one end and the spinal cord is going down the other. You see two arrows coming down, and that's where the spinal cord is actually coming out of the back part of the brain. So if you look at this image, there looks like a little bush here, and it looks a little squished, Normally it should be a nice round structure. So you can see the back part of this brain has kind of been compressed. The normal brain tissue is kind of being pushed into an abnormal position. And you see the brain underneath that bush kind of make a little kink in it, essentially. We call that medullary kinking, so the back part of the brain gets tweaked as it's leaving. If you look at the far arrow on the far side of this image, you see a bright white region that should be within the spinal cord, and this is called a syrinx or syringomyelia. So this malformation crunches up the front part of the brain, it disrupts the normal spinal fluid flow, and then we get these big pocketing of spinal fluid in the spinal cord itself. And so this can lead to a bunch of different clinical signs for the patient. Most often we hear reports of neck pain. They'll guard their neck. They don't want collars or leashes to be attached to their neck. And then also we will see very frequently what we call phantom scratching. So if you touch along the neck of these patients, they'll start scratching, and sometimes they're completely missing. They're only scratching the air. Sometimes they'll also scratch kind of at their flank, depending on how long that pocketing of fluid goes down the spinal cord. This is common in Malteses, but kind of the poster breed for this would be the King Cavalier Charles Spaniels. So they're also very, very overrepresented. So for these patients, we talked a little bit about the clinical signs. Again, they can have normal blood work, normal x-rays. We kind of worry about this malformation based on the breed that is coming to us, and especially if there's phantom scratching. So they we'll have to do an MRI to fully diagnose these patients, as you can see, and then we look for that pocketing of fluid. We look for the crunching of the back part of the brain tissue and some of the kinking of the back parts of the brain. They don't necessarily have to have fluid changes to be clinical, so they think that some of just the squishing of the back part of the brain can also be at play. There's also two treatment types for this disease. So again, there's a medical management type. So pain medications and steroids can also help. So bringing down the inflammation, bringing down the swelling that happens with this pocketing of fluid. And then nerve pain medications, things like gabapentin and pregabalin, can help cut down on some of the feelings that we suspect that these patients get, where they're having these phantom scratchings. Humans that have a similar condition, the Chiari malformation, report feeling like a burning sensation sometimes in their neck, and we suspect it's hitting certain pathways that run along the spinal cord, and we think that this is why the dogs act this way, and that they probably experience similar discomfort and sensations. For patients that are very, very clinical, so generally patients where they've got a lot of fluid and to the point where it's also affecting their ability to walk, or they have ventricles that are getting really dilated and starting to fill, there are some surgical management techniques. So involving going towards the back of the skull and essentially removing some of that flat part of the occipital bone, the back part of the bone of the skull. Basically, by removing some of this bone, our hope is to allow that spinal fluid to flow more freely and keep it from pocketing. There is a risk of recurrence. For some of those patients, they can put down scar tissue and have things similarly rehappen. But for a lot of patients that I've seen, they do get some improvement, especially if they're very severe and can be a little bit more normal. Again, these are patients that we kind of follow out and keep up with. The fluid pocketing can get worse throughout life, and so we do want to keep up with them, make sure they're comfortable, and make sure that we don't see worsening neurological signs, specifically their abilities to walk and place their feet appropriately. All right, so we'll continue moving forward onto our next image here. So the next one we're going to talk a little bit about is deafness. So this can happen in a lot of different breeds, but particularly white breeds can be predisposed to being deaf, and they can have this as a congenital issue, so from birth. And specifically what can happen in white breed dogs is that they actually need a little bit of melanin, a little bit of pigment on some of their inner ear structures that are important for receiving the signals and the vibrations of sound and transmitting that to the brain for them to interpret. Dalmatians are also very predisposed, and about 30% of Dalmatians can at least have unilateral deafness because they don't get a little bit of pigment on those ears. And Maltese, being a white dog, it tends to happen. Blue-eyed and white cats also are very overrepresented for having this deafness. So truly diagnosing deafness can actually be a little bit difficult in animals, because obviously we can't communicate very clearly with them about, hey, how much can you hear and out of which ear? So similar to people, we have some electrodiagnostic testing that we can do to further suss out whether or not a patient is deaf. So this is a nice little picture here. This is a little sedated dog, and we were actually performing a BEAR exam. So BEAR is an acronym that stands for Brainstem Auditory Evoked Response. So what we are doing in this is he has little tubes, a red one and a blue one within his ears, and they're transmitting clicking sounds similar to people. Normally we can wear some headphones, but for dogs we'll plug their ears with the little cones. And we're transmitting those vibrations into the ear, and we have some special electrodes placed along the top of the head and along the back of the ears, and we'll have sometimes a reference near the shoulder blades. And what we're doing is recording the electrical responses of the brain and the nervous tissue to see where that signal is traveling and if it's traveling appropriately. So some of the things that we may see is that these dogs may have normal waveforms and they can hear out of both ears. Sometimes we can see normal waveforms in one ear and a flat line in the other, meaning they have unilateral deafness, so they have deafness in one ear only. And then sometimes for some of these patients, we will see a flat line, no waveforms in either ear. And those are patients that are truly deaf in both ears. There's always the chance to have a great quality of life with deafness, similar to people. The big thing with animals that are being deaf is safety and trying to keep them away from situations where they can harm themselves, because obviously they can't listen to verbal commands or respond on cue. There's very nice now vibrating collars that can be used for some of these patients, and you can use them for training and also for recall if they're doing, running around at a dog park. They can be vibrated, and they say, hey, my owner is calling me, and turn around and look back. I have, I believe, a quick example for you here of what these waveforms can look like. So this is what we would see on our machine as it reads out the electrical activity. So in the very top line that has some waves, and it also has a little L out to the side, so that's the left ear for this patient. And you see waveforms here. So this dog has some normal waveforms and can hear out of that left ear. If you look at the second line down and it has a little R off to the side, you can see that this is what a flat line looks like. So this patient does not have hearing out of the right side of the ear. Unfortunately, there is no major cure for deafness in people. They can do some cochlear implants and help somewhat with hearing aids. There are some studies that look at that in dogs, and we may be able to restore some function. It's just very difficult to get them to not go at those instruments and to keep these instruments in. So we generally don't practice any kind of hearing aids or hearing implants for these guys, mainly just safety and monitoring and keeping them in a good safe environment. All right, guys, so we're going to talk about our last disease here, and I have lots of questions to go over. So the last one we're going to talk about is we're going to talk about idiopathic tremor syndrome, and I have a video of that to share here. So idiopathic tremor syndrome, white shaker syndrome is another name, or idiopathic cereballitis, is an inflammatory disease that happens in the back part of the brain. That little bush that we saw earlier that was a little squished, that's actually called the cerebellum. It's a very important structure to help with fine-tuning movements and also to help you touch things in a controlled and precise manner, as opposed to being super wild and over-exaggerated. So this is a little guy that I treated a few years back. You can see this guy has a very frequent head wobble. He has a hard time maintaining a normal head posture. When he's walking, you will see him doing these very high stepping motions, and we call that hypermetria, over-exaggerated. So he has inflammation within his cerebellum that causes that. And as you can tell, he's not a little white dog, so why we don't call them little white shakers all the time and prefer the term idiopathic tremor syndrome. These patients, as you can see, generally present for overall incoordination. So they have a lot of intention tremors, they have difficulty walking a straight line, and can be very over-exaggerated. So we will do an MRI and a CSF tap for these patients as well to try to fully diagnose them. The tricky part with this disease is very often the MRI and the CSF tap are normal, and some of the patients that have... All right, sorry guys, technical difficulties there. So the MRI and the CSF tap are often very normal for these patients. So it can be a little bit tricky to diagnose, but on the patients that have had an autopsy performed, we do see inflammatory lesions for these patients. So the treatment of choice for them, again, is to kind of suppress the immune system. We do feel that this is an immune-mediated attack on the brain tissue. So generally, we'll start with prednisone for a lot of these patients, and again, slowly wean them as they get better and try to get them on the lowest possible dose or potentially off of the medication. Sometimes they need some more aggressive immunosuppression therapy. This little patient did need more, but he did come back to us and looked much better, more normal, didn't have as much intention tremors and shaking, but he did take a little bit of work to get there. So overall, these patients can have a really good quality of life. Relapses with this disease are definitely possible. So as we wean them down or get them off, sometimes at that point we'll start seeing signs again, or sometimes even years later we can see these patients come back and they've redeveloped the signs, and we have to kind of start this process over again. But overall, they generally tend to do pretty well. All right. So I think this is a majority of the diseases that we wanted to cover today. I will open this up and we can do some questions, some Q&A answers for you guys. I'll go ahead and start with some of our previously submitted ones, and then I'll go through the ones that we're getting now. Sure. All right, awesome. So some of the ones we had previously submitted was, so we're curious about what the protocol is when your dog starts to relapse. I think this is specific to the necrotizing meningitis or the immune-mediated meningitis that we deal with. And what are the recommended medications for highest survival? Also wondering if there's any statistical information on the survival rate for newly diagnosed pets. Information is hard to come by, and this owner felt a little helpless when her pet was diagnosed, and so she would like there to be some kind of knowledge out there to kind of help relieve some of that sense of helplessness. And so for sure, I think those are all really great questions. So the difficulty with dealing with these immune-mediated meningitises and the MUEs, MUOs of the world is that we unfortunately don't have a standard of care. This is the best treatment just yet. So we don't have a ton of studies where they compared this drug and that drug and this drug, and they randomized these dogs and they followed them out for years on end. So we don't exactly know which ones are best. It is also very clinician dependent. How are they trained? Which drug do they use? What do they see clinically work? So I won't say that there's a best drug. Personally, I like to use the drug Cytosar, which is a chemotherapy drug, and I also use prednisone like we talked about in the short term because it's a little faster acting. And so to bring down the immune system, what we'll do for these patients is start them on the steroid and slowly taper over time, and then we'll start Cytosar at the same time. There's a bunch of different protocols. Sometimes there's an infusion where they get it as a drip, and sometimes there's protocols where they just get an under the skin injection, and they may get it once a day or twice a day, or they may get 4 over a 2-day period, again, just kind of depending on the clinician's comfort and experience and what's best for that patient, and then we'll follow them out. As far as survival rates, when a patient is diagnosed with meningitis, generally the prognosis is going to be fair to guarded in the beginning, meaning we're not really sure how that patient is going to go. We have to watch how that patient trends. If you look at some of the research, the survival times can be quite low. So like averaging, sometimes they'll say even as low as 14 days. That's small case numbers. That's some cases that are in the past where we didn't fully understand sometimes how to treat this disease. So we can get some better outcomes for sure. So again, we don't have specifics, but up to about a year can be some survival for some of the GME dogs. And again, that's an average. So some dogs are way higher, some dogs can be lower. But for necrotizing meningitis, the more severe forms, most of the research will point to somewhere around 6 months. But again, I've had cases that have done better. And it really just depends on how is that patient doing and adjusting the plan based on where that dog is at that time. So those would be, kind of some of the survival ways. Unfortunately, it is a disease that we have to watch closely. Generally, most of the literature is pretty consistent that the first 72 hours are kind of the most critical from diagnosis, and that's where we can see some death related to the meningitis, or the most frequently. So we'll want to watch them very closely for 3 days, and I tell my owners if they've made it through 3 days, they're more likely to make it to 3 weeks, 3 weeks more likely to make it to 3 months. Once patients have reached 3 months, they are more likely to make a better long-term survival, so a year or plus. And there's also some research that shows rechecking an MRI or rechecking a spinal fluid tap at some points along the line. If they have normalized, those dogs do a lot better than dogs that still have inflammation lesions within the brain on the MRI, or their spinal fluid is inflamed. So it's still kind of a developing area. It's something that is obviously serious and we want to watch closely, but those are all things that we would do and could quote based off of literature that we have so far. So next one was, how common is it for a Maltese to seem fine and then suddenly get very ill or even pass away? It sounds like this owner unfortunately had a pet that was diagnosed and only lived a very short time and basically wasn't even able to get a whole lot of treatment before the pet declined. So that's definitely possible. Like we said, I think that 72-hour window is pretty critical, and some of the research supports that 72-hour window. Unfortunately, dogs and cats as well can be really, really good at hiding an illness. The brain has the ability to adapt really well in animals. So, we showed the hydrocephalus with lots of fluid. We showed that brain with lots of inflammation for meningitis. Sometimes these pets are overall very normal on their neurological exam, and it's not until they have a seizure or something like that they're brought into us. So their brain has an amazing ability to adapt, and to the point where it can't adapt anymore. And then sometimes we see a very rapid and sudden decline, especially for the more necrotizing forms of the disease. So it is definitely possible, unfortunately, to have what you think is a very normal pet and then it get very sick and potentially go through very bad complications, unfortunately, when we have neurological disease. So definitely possible. Last one that we have pre-submitted here is, again, asking about typical protocol for medication therapy and typical expectations for relapse. How frequently do we taper, and how often? And then I think what signs and symptoms to look out for specifically for meningitis pets. So we kind of talked about the treatment so far. Generally what I will do with prednisone is I will do about a 25% decrease of the pred every 4 weeks. And again, that's very patient dependent. If the patient seems like they're not doing as well, I may do a lower dose, or I may not decrease them that go around. It just really just depends on how the patient is doing clinically. But that is my general protocol. Some people will do slower, some people will do a little faster. It's again up to the patient and the doctor. As far as the clinical signs that we'll see, it really just depends on where that inflammation is. So front parts of the brain, we can see circling, we can see behavior changes, we can see seizures. If it's more in the back parts of the brain, we can see balance dysfunction. So things like head tilts, rapid eye movements that we call nystagmus, again, circling, falling, can't walk a straight line, seemingly drunk, can definitely happen. And then you can have even more severe alertness changes. So things like being comatose is possible depending on where that inflammation has taken a hold of everything. So I think the last one was specifically about how long can relapse last. So for all of these immune-mediated diseases, you do run the risk of relapse as we're trying to wean these patients down. So you have to watch them very closely, and the relapse can last a couple of hours, a couple of days, or it can be more prolonged, and depending on the damage that the inflammation has done, you can see residual damage from the inflammation. We may not be able to get them back to where they were or fully back to normal. But I would say for most of my patients that relapse, we make adjustments, we add in medications, we do injections, however we feel we need to do. And then I'll generally check them back in the next couple of days to a week, and then repeat their exam. Where are they now? Has this improved? Has this gotten worse? And then make further adjustments. So we basically keep a close eye on them in that period and go from there. All right, so I think that was all of our pre-submitted questions. So we have probably another 10-20 minutes left. So I'm going to see if I can switch over to our Q&A here. And ask some of these questions. So we have a question here. So, sorry guys. So we have a question here. I'll read it out loud and then I'll minimize it. So our 5-year-old Maltese has been diagnosed with GME. She weighs about 2 kilos and she's on 5 mg of prednisone once a day and cyclosporin twice a day. She's not improving and all 4 legs are becoming lame. What are some suggestions? So that's definitely a pet that you want to take back to your veterinarian or your veterinary neurologist and say, hey, I'm not seeing some of the clinical signs or clinical signs of improvement that we would want. And I would have them weigh in. So they're going to want to repeat that neuro exam and see where things are trending, which parts of the nervous system have started to be affected or are not improving. And they may switch up medications. They may be able to go up on some medications that you're on, or they may want to switch medications completely. So that is definitely a good question, but those are the types of things that you definitely want to bring up to your veterinarian. Say, hey, this is what I'm seeing at home, and make adjustments as they see fit. All right. So let's see if I have any other questions here.
They might be in the comments.
In here? Okay. So just scroll through here.
Mm-hmm.
All right, guys. So I'm going to scroll through some of our comments here and see what other questions we have. So we have one question here that have a patient that's on Cytosar that's working great and we discontinue cyclosporin. When would you consider adding an autoimmune drug again? So it really just depends on the patient. So if a patient is holding steady or improving, I generally don't want to add in more medications. But again, it depends on that neuro exam and what your veterinarian or veterinary neurologist is seeing on that patient, whether or not they need to add anything in. But if a patient's doing well, generally I'll follow the treatment protocol through and not have to make a ton of changes. The fewer drugs that you have to put out there can be helpful, keep side effects from happening, especially with prednisone, and to help prevent secondary infections. So if you have a patient that's on a lot of immunosuppressive medications, things like bladder infections, skin infections can creep up because their body can't quite fight that off. So that's a great question there. So going through, so we have another question here. A dog that was diagnosed earlier this year in January, originally on pred and cyclosporin, but she's had a couple of relapses. So they've started Cytosar and they're doing great. Oh, not a question. But yeah, so this is kind of a case example, a point where you have to judge it on what that patient is doing, make adjustments if they're appropriate with your veterinarian. And sometimes it is a matter of trying to find the right drug or the right combination of drugs for that patient. Some questions here about actively involved in research for these. Currently not actively involved in research in meningitis. Did and am working on a paper for looking at relapses for these patients, but I don't have any active kind of things going on. All right, let's see if there is any other questions here throughout the comments section. Any more here? All right, guys. Well, it looks like I've gone through quite a bit of questions here and went through some of our pre-approved stuff. So if we don't have any other questions, I think we'll probably call it done for today. But if you guys have any other questions, feel free to reach out or email, and we'll be doing the next kind of breed predisposition or breed breakdown, so to speak, probably in the next couple of months. Hope you guys have a great day and stay safe out there.